Hello and welcome here at EAO's Just Ask Live. This is your monthly live and virtual appointment with a leading expert in the field of implantology. And tonight, we're talking about ceramic implants. My name is Gerrit Heijkoop and I'm the host of the EAO channel and of these EAO Just Ask Lives. And I will try to relay all your questions to our expert. And tonight, I'm joined by Dr. Michael Payet, who is the Vice Chair of the Department of Oral Surgery and Orthodontics at the Medical University in Graz, Austria. Michael, good evening.
Good evening, Gerrit. Hello. Hello from Graz.
Yes, it's all working, it's all running, and I just posted in the chat, if anybody who is watching right now can share with us who they are and where they're watching from, and already some people have done that. Let me make a quick shout out to Victor Palari, he's here. Good to see you, Victor. Martini says, hi, nice evening. And also our expert from last month's Just Ask. If you haven't seen it, go check it out on the EO channel. Alberto Salgado is with us from Spain. We also have Philippe Breguin with us from the EA office. Good to see you, Philippe. And also Jens Taerts is here. Greetings to all from Zurich. And Jens is one of the case submitters that we will address here tonight, because that's what we're going to do. You and I have been preparing, Michael, and we'll go through the basics of ceramic implants and then go dive deeper into some specific questions and cases that have been submitted. If anywhere during this broadcast you have a question, use the feature of the live chat, send your question right in, and I will take them on your behalf. So, well, Michael, if you're ready to go, let's start with the basics. What is the need to know before we start on talking about ceramic implants?
So thank you, Gerrit, for this introduction. Before we start with the topic on ceramic implants, I would just like to, so it's on the table, to show our scientific collaborations, because on this topic we're using the products of several manufacturers, so everyone is aware of the collaborations we're involved in, and so that is there. So I just want to start this at the beginning. So if we speak about ceramic implants today, that's this wish to establish metal-free solutions within implant dentistry is not new. It's not new at all. It's almost as old as the history of titanium within implant dentistry, because if we look at the first implants that were published and marketed, we go back to the mid-60s and late 60s already. And these implants were out of aluminum oxide or alumina. And one of the pioneers was Professor Sami Sandhaus. He unfortunately died last year. He was one of the pioneers. He was aged 92, and he invented the so-called CBS bone screw. But also other manufacturers were there. So the tubing immediate implants, some of our listeners, of our colleagues may use these implants, may know these implants. So the story of aluminum implants, alumina implants ended because they had to be removed from the market because of very high fracture rates. And just recently, by chance, one implant jumped into our clinic, and he had some interesting shape. He had an anchor-shaped implant here in the lower jaw. And also this fractured, although this it was lasting for 30 years, but most of the alumina implants fractured already at a very early stage. So I had to remove this implant, which looked really very interesting. I've never seen an implant like this. And for the patient, it was not a fun thing to do, but it lasted for some time and helped the patient for a long time. So anyway, if we speak about ceramic implants today, we speak about a totally different material, zirconia. Zirconia is also an oxide ceramic, and it's existing in three different phases, with the cubic, tetragonal, and the monoclinic. And the tetragonalic phase is the one which offers the best mechanical properties. And however, if we put some stress on material, there might be some phase transformation from tetragonal to monoclinic. And during this phase transformation, we do have a volume increase, which is nice if it's happening in the small environment, because it offers also the option, if we do have some micro cracks, which we can see in all the ceramics, it's something like a self-limiting or self-repairing mechanism. However, if these micro cracks happen on the surface of the implant, it's not so ideal, because then it allows water to enter into the material and may cause instability. This is something that is called aging of zirconia, which has to be regarded. I will come later on to this when we consider treatments for example, for peri-implantitis, and we cannot do a grinding, but also for surface manufacturing, we cannot use the same procedures for surface preparation as we can use for titanium. However, after more than 10 years of using zirconia implants in clinical application, I've never seen this being a problem, and I've never seen fracture of a zirconia implant. However, so we do not know whether this is of clinical relevance for us. If we go back, zirconia has been undergoing quite a success story within medicine, because it's been used for over 40 years in orthopedic surgery for hip replacements, and also in the car industry, in the plane industry. So the material properties are very, very promising and very convincing. But also within dentistry, it's been used since the late 90s for bridges, crown frameworks, abutments, but also as an implant material. It's been used since the late 90s, early 2000s. And if we look at the market penetration right now, we can see for implants and abutments, and this is a calculation from 2017, 2016, so it's quite from nowadays, and it's still at a very low phase. So we are still very much at the beginning here of less than 1%. But if we look for crowns and bridges frameworks, it's more than 30%. And for layering, it's even up to 90%. So we can speak of quite a success story also within dentistry already so far. So this just as a short introduction.
Yes, this is a very quick overflight of the history of ceramic implants and the material zirconia specifically. Thank you for that. In the meantime,
40 years in 5 minutes.
Exactly. In the meantime, let me welcome all our new viewers on board. Welcome here at the EAO channel. We're live with Michael Payet from Graz in Austria, and we're going to talk about certain cases that have been submitted beforehand. But we also have the ambition to answer all the questions that you might have regarding anything that Michael says while we're live on the show, or anything that you are wondering about ceramic implants already. And we see some more people making a shout out. Let me say hello to Manuel Reinisch from Austria as well. We have Christopher Appelquist here. We have Brenda Martins from Montpellier. Good to see you, Brenda. And Buka Joffrey is from Ljubljana in Slovenia. So we're truly uniting an international crowd on the topic of ceramic implants here tonight. And I think that's a nice segue into our first question, Michael, because that was submitted somewhere last week, all the way from Brazil. Good morning, Carlos Elias. I hope you're watching this live. And if not, you must be able to watch this in recording, because he submitted not so much a case, but more a question. Since we're talking here at EAO, the European Association for Osseointegration, he's wondering, what do we know scientifically about whether there is osseointegration, integration between bone and the foreign material with ceramic implants? What can you say about that, Michael?
I think that's a question of the question, whether if we consider zirconia as an implant material. And this is also one question we always need to address when we speak about zirconia. So can we expect the same kind of osseointegration as we're used to from titanium? And this question can be answered, I think, very convincingly, also with early publication. For example, here's a publication from 1985 from Thomas Albrechtsen, and he observed the same type of interface on zirconia and titanium implants that were placed in rabbits. And also later on from Davis, a publication in 98, you could see, I think that's a very important statement, that osseointegration is a type of post-traumatic tissue reaction, and it's not a specific reaction towards titanium. So we can see all these phenomena we used from titanium implants, like distance and contact osteogenesis, also on zirconia implants. And there is many more studies which I always have prepared when I speak about zirconia, that tell us of similar bone to implant contacts, removal torque values if we use the same modified surfaces as we have them for titanium. So, and also loaded studies here. So there's quite a evidence on osseointegration. But I think, and that's also a very important point we need to consider. The first zirconia implants, they had a very smooth surface because it was not to manufacture and to structure a zirconia surface is much more difficult and much more complicated than it is for titanium. And so you cannot use sandblasting. It doesn't have the, and also grinding and everything. It doesn't have the same effects. But this was also quite a learning curve for the manufacturers. And they managed to have the surface roughnesses we are used to also from titanium, and which allows us also to expect osseointegration within similar time frames. So at the early stage, for the first zirconia implants, we really had to wait for 4 to 6 months at least to manufacture recommendations. But nowadays, manufacturers give us the liberty to use the same healing times for zirconia as we are used to for titanium, so 2 to 3 months. So we don't need to wait longer anymore. So I also have a case which shows us. So that's a clear yes. We can expect osseointegration.
Exactly. Scientifically proven. Yes. You have a case to show as well.
Yes, I think this case would fit quite nicely here because it's one of our early cases, which we've been treating in a study. It was a young patient, which we showed up at our clinic in 2008 with a missing lower molar on the left side, and we included him in one of our studies, which we were performing on single-piece implants. And this was still the first generation of zirconia implants, really with a very smooth surface. However, that's the surgical phase insertion of this single-piece implants. You always have the abutment looking out there. It's a long, thin screw here. And within this study was the protocol. If there was enough primary stability, we even did go for immediate provisional intraocclusal provisional restoration. That's the provisional restoration in 2008, immediately done after surgery. And that's some weeks after the surgery. And that's the final restoration in occlusion, which was manufactured some months later. And then the patient showed up one year later, and because he moved to another town, and he came back like this. And we were really shocked when we saw this, because an orthodontist has put much more trust in our zirconia implant than we would have him liked to, because he was using our single-piece zirconia implant as a skeletal anchorage as a retention for his orthodontic work. But it didn't do any harm to the...
Michael, did you ever figure out, was this unconsciously? Wasn't the orthodontist just not aware this was an implant, or was it on purpose because he thought this would be a good anchor point?
Yeah, he was very happy that the implant was there, but he was not aware that it's a ceramic implant. So exactly. So because the orthodontists, they very often ask us to place some implants to have a skeletal anchorage, and he used it. He abused our holy zirconia implant, but it did not do any harm, because this is the situation some years later, and it's still there. So also on the long term, that seems to be osseointegration possible, and so we still can answer. I think I can answer this question with a clear yes. Osseointegration is possible, and also nowadays within a similar time frame as we know it from titanium.
Perfect. Sounds good. So that's a good basis to start from. It's a proven track record. In the meantime, a few shout outs. We have Juan Carlos Obando from Ecuador joining in. I guess, good early afternoon. I think there must be about a 6-hour time difference there. Bosjam from Slovenia, Brooke from Algeria. So welcome. You see, the live chat is functioning. If you're just joining us, if any time during this talk you have a question, please use the live chat feature to send in your questions, and we'll pause and answer your questions first. In the meantime, many people have been submitting cases beforehand, and you already mentioned, Michael, in the past, this was when this started in 2007, 2008, 2009. It was a single implant procedure, right? You could say perhaps the somewhat easier cases, but we saw 3 case submitters wondering about the 2-piece possibilities for ceramic implants. And the first one we want to highlight is Jens Taarts. We already saw he was joining us online. Welcome, Jens. And it's nice to make a shout out to him. He is also the president of the European Society for Ceramic Implants, of which you then
Jens,
are.
good to see you.
Yeah, you are a member on the scientific board of this same society. So Jens, thank you for participating. And well, take it away. We have 3 questions regarding 2-piece implants, right, Michael?
That's right. That's right. So you mentioned it already before. So when we speak about zirconia implants, everything started with the single-piece implants, as we've seen it just in the case I presented. And because the manufacturers were not able to create ceramic screws because of the stiffness of the materials. If you insert a ceramic screw into a ceramic screw, it will break very easily. So the manufacturers tried to overcome this. And because when you use single-piece implants, you still need to consider some aspects, which I just briefly want to show. You always have some kind of immediate load application because you always have the abutment in the intraoral cavity. And so the recommendations were to prevent this were, in my opinion, is a drawback within implant dentistry because the recommendations were that the patients should wear protection splint during chewing activity, but try to chew and eat with a protection splint like this. So that's not very comfortable for the patient. And also these protection bridges, it's hard to clean. So we were going the pathway which I was showing before. We were going for an immediate intraocclusal restoration here, which is probably the most comfortable a way to overcome this. But so everyone was waiting for the 2-piece solutions here. And the early beginnings was that was an adhesive fixation of the abutment into the ceramic implant. And we also did a study on this. Our prosthodontists hated us at the beginning when we were asking them to adhesively fixated abutments into implants. Just imagine this you have to do this in a posterior side and in a narrow premolar side. So it's everything on bone level but anyhow, they learned how to do it, and these implants almost now after 10 years still work. So this abutment connection works, but it's not very practical. So the manufacturers went the different pathways and used different materials like PEEK components or carbon fiber screws or even titanium inserts within the ceramic implant. And Jens Taarts, he was submitting. Thank you very much, Jens. He was submitting a case where he was using a carbon fiber screw on 2 2-piece implants, which he was placing in the second premolar area. And this case he was submitting is very nice to show that with the 2-piece implants nowadays, you can follow the standard protocol, which we are used to from titanium implants. So it's a surgical protocol here and a covered healing. And after some months, he does a second stage surgery and conventional impression technique, and then screw retained fixation of the screw. And then everything is covered with a composite resin. And here the follow-up after 1 year looks very nice papilla formation, very nice soft tissue condition. And so this case seemed to work in a short run. Second case that has been submitted on this topic, I think I'm just showing all the 3 cases because then we can discuss the questions in a row. And it shows, because we've been receiving 3 cases on the same topic, just different materials, shows that I think this is where the core interest is on ceramic implants. How predictable is the application of screw type connection between abutment and implant? And so the next case by Martin Koller is the evidence for PEEK components, because some manufacturers have recommend to use PEEK screws or PEEK components. But that's a case of the sinus lift or a simultaneous sinus lift, also a two-piece implant is placed. So that was Alberto's topic from last week. Sorry, Alberto, for interfering into your topic, but it's just...
Well, it's good to mention that for those viewers who've missed it, please browse around on the EO channel, because there you'll find the EO Just Ask specifically about sinus lifts with Alberto Salgado, which we recorded last month. So that's available for recording throughout the future.
It was a very cool session. Congratulations, Alberto.
All right.
And
but you were talking about the peak integration, yeah.
Yes, and there was the peak component here, and also here the follow-up looks very nice. What is interesting that the components were not already opaque, so there seems to be a gap in here, but clinically it was not. So also here we can see nice soft tissue condition and nice follow-up. So the case 3 was on the third option I was mentioning, was also coming from Switzerland, from Sebastian Kühl, and he sent us a case, also a premolar here, and that's implant type with a titanium insert, which is also one of the options to overcome this problem with the abutment connection within ceramic implants. And here ceramic gingiva former, but you can see the titanium insert. So the inner life is out of titanium, also screw retained fixation of the restoration here, and this is the follow-up. Also here, very nice soft tissue healing and nice papilla formation. And this is something which we see very often around ceramic implants, and also here the follow-up is very nice. But just to answer the questions, is there evidence?
Yes, that's the question. What is the evidence and the experience with these 3 alternatives? What is there any direction where we're pointing from a science perspective?
Unfortunately, not too much, because if we look at this systematic review that was published very recently by Stefan Röhling, shows us that on one-piece implants, he could include only 14 studies, and two-piece implants, it's only 4 studies. So and also very recent studies, so which give us very promising data on the short term and on the midterm outcomes, but that's
and promising data, Michael. You mean you don't see any differences between these 3 solutions? There's no preference to one or the other.
That's true. That's true. So we can see neither in survival rates, nor on the radiographic, nor on the clinical parameters. There's not too much difference, or not any significant difference between the classic titanium implants and the ceramic implants, which we are using nowadays. So I think it's still too early. It looks very good on the short run, but it would not be serious to give any recommendations whether it's wiser to use this or that material for two-piece ceramic implants. And so we are very much at the beginning of the journey here of this fascinating topic, but so we are very curious in the future. And we also have the great honor, maybe I may announce this as well, we are just starting a multi-center project also with 2 Swiss universities, with the University of Basel, which has the lead, and the University of Zurich. And we're starting a multi-center study exactly on this topic. So we hope that we can contribute in some way to deliver data for the future here.
Exactly. And what exactly will you research in this project, Michael? Will it be the difference between the 3 abutment connections?
It's the difference. It's a screw type connection as well on the 2-piece ceramic implants compared to a classic titanium also screw type connection. So
it's still titanium versus zirconia what you're studying, or
yes,
is it also
that's
specifically
right.
Between the different 2-piece connections?
No, it's still zirconia versus titanium, because that's the basic data we are looking for. This is where we need to start.
At this moment, still.
Yes, absolutely. Yeah.
Clear. Well, let's take some questions, because our audience is warming up. If you're just joining us, this is how it works. There's a live chat feature here on YouTube, and you can submit your questions. Let me first make a shout out to Lenka Likar, who has a question. about how to manage fractures. Well, we'll get to that in a minute. The first question that came in just before was from Victor Palari, and he's asking, we're talking about single piece, quite simple use cases up till now. He's wondering, is it possible to place ceramic implants at an angle? What is your experience, or what is the scientific evidence? Let's always make a distinction between clinical experience and scientific evidence here.
I think that's a very good question. Thank you, Victor. And that's probably also one of the reasons why the market penetration of ceramic implants has not been so high, because it's also from a prosthodontic point of view. With the single piece implants, you have to place your implants in a very precise manner. So because you don't have the chance to, at least to my knowledge, I don't know any single piece implant that has got angled abutment in itself. So at the early stage, it was like this, that the first study we were doing, it was allowed to grind the abutment. So you could overcome a little bit of deviation. But nowadays, no manufacturer is allowing this anymore, because as I was mentioning at the beginning, from the material properties, if you have uncontrolled grinding within a dental office, this may cause some initial microfractures and may induce aging of the material. And so you have this straight abutment, and which may limit its application also in some prosthodontic situations where you may need to go for an angled abutment. So I think that's very, very good questions. And so that's definitely a drawback of the single piece implants as well. That's why everybody's waiting for the two piece implants to overcome this problem also as well.
Well, and that then is probably a hint into his second part of his question, and also a question sent in by Sasha Marin from Banja Luka, because Victor also asked, and how about all on four? And Sasha Marin is asking, what is your opinion? So he's asking about an opinion regarding all on four with ceramic implants.
I think that's by far too early. I think there's, we're in the phase of single piece implants, of single tooth gaps, and this is where we need to start the journey from. But he's asking for my opinion, so I think it's if we can overcome these first small limitations which we have, it will probably be possible to use also ceramic implants for all-on-4 concepts. But again, that's there's nothing about all-on-4 concepts on ceramic implants that's is related to any scientific recommendation that can be given here at this point. But
exactly. So basically, the key message is that at this point, we're still in a place where we are scientifically proven the concept of ceramic implants in a basis in comparison to titanium implants. And then from there on, we step by step make things more complex.
Absolutely.
Correct? Yeah, exactly. Well, in the meantime, we have some more people joining. Alain Chavanas, hi, welcome. And also Isabella Rochetta is joining us from Italy. Isabella will soon be featured on one of these Just Ask. So great you're joining us as well, Isabella. Let's move into another case that was submitted earlier, and that also then probably will answer Lenka Lika's question about how to deal with fractures, because we had a case by Christoph Pertl on a patient with a fractured ceramic implant.
Absolutely correct. This case was submitted on also on a very, very I think important topic about the incidence of fractures, and this is what many people have still in the back of their mind, just as Christoph here, and he was asking how can explain this implant fracture of this narrow diameter zirconia implants, and he was sending us a case, early case in 2007, where he was preparing the patient for edentulysm, and he placed several zirconia implants in the maxilla in 2007. And
so
he even
this
went
was in a very early phase, right? 2007.
Yeah,
That was at the start of the whole ceramic implant momentum.
very much so. So here we speak about I would say the first generation of zirconia implants, also from the manufacturer, or from, if you look at the macro shape, and also from the surface and everything. So he's describing that he also went for an immediate restoration of these 4 incisor implants here, but within only, and this is really interesting, within 29 days, so within less than 1 month, he experienced a fracture of the central incisor implant in position 1-1. And he just put it asleep and placed the bridge on top of it. And he was following the case now for many years until 2019. So we speak of a period of over 12 years already. So I think that's I think there's not many cases, and especially other edentulous patients out there with a follow-up like this. But to come back to the question why this implant was fracturing, I can answer this question maybe with one publication, that he was not alone observing these fractures of narrow diameter implants in this stage. And this is related also because here we have a publication by Michael Gallert in 2012, and where he could observe the fracturing of 13 of 170. So we have a fracture rate of nearly 10% within 3 years in function, and most of them were these diameter reduced implants. So, and he was concluding on this, that this was related most probably to the early surface modification, which was done by the manufacturers in the same way as they did it with the titanium implants. They were using large particles to sandblast the surface, which was, as described before, which was creating micro cracks and was provoking aging. And so this is, they totally changed the protocol for that. And this is something that was part of the learning curve also for the surface treatment for zirconia implants. Yeah. So, but this is something, and I think this is important also for the audience now, this is something that is something from yesterday, because we see also within fatigue stress tests that have been done by manufacturers who are producing similar narrow diameter. There's 3.3, 3.5 millimeter of diameter implants, and they withstand loading forces which we cannot apply within our mouth. So that's, but this explains probably the failure of this implant. And so this is maybe addressing another topic which we need to consider. If we see these implants, it is really not very comfortable to remove a zirconia implant. And Michael Gallert was showing this here. He was using a piezo device, and you need to create quite a crater to get it out. Because because of its stiffness, it's breaking from one piece to the next piece, and you really have to tickle it out of the patient's mouth, and it's everything else than minimally invasive. And because if we look at, we are used that we can remove teeth and also titanium implants with explantation kits in a very minimal invasive manner with counterclockwise screws, so that is really very easy. But this is not possible for zirconia implants, because we cannot put this first screw, we cannot drill into zirconia. And I experienced myself one case, which I've prepared here just for answering also this question. I was fracturing myself once a zirconia implant when I was inserting it, because I was not following the right surgical protocol. I was overloading it. I was putting more Newton centimeters during inserting the implant. So it fractured here. You can see this, this first implant here fractured. And so I had to remove it, and it really was a nightmare. You can see I was using explantation drills and everything, and it fractured again. But I was able to place another implant, and dentist could restore it. I didn't restore it, but restored it with a bridge, and it works also now for almost 10 years now. So, but removing a zirconia implant is nothing nothing funny, but in some cases it was necessary.
So if we really try to tailor that to the question that, let me pronounce, Lenka Likar has asked, what to do with a fractured zirconia implant. Because you shared with us, it's something from the past, so we can assure our patients who get new ceramic implants that is a reputation that is not that valid anymore, but that still people might come across a fractured implant. You showed this one case where the implant was put to sleep, as you mentioned. Would you recommend that? Or let's start with, are there any studies done on what to do with fractured ceramic implants?
Well, I was showing the study by Michael Gallert, and I think we can answer this question. Not there's no evidence on that, but but we need to answer this question with if we have the luck that it is not reducing the quality of our prosthetic concept, I would rather put it asleep, as Christoph was doing it. But just in this case here, like where we had this tooth gap, where I would not have placed the cantilever to the anterior side, where I was really looking forward to get another implant, because the tooth anterior to the tooth gap was about to be extracted as well. I would rather remove it. So if it's not absolutely necessary, it probably doesn't do any harm to leave the implant in there.
Yeah.
As long as there is no sign of inflammation, and this is what we see quite rarely around zirconia implants. So I think Christoph was doing taking a smart decision on this.
Yeah. Yeah, and to be clear, so we're now talking about we're sharing clinical experiences, right? I mean, this is one way or the other, and it's
the level of least evidence.
Exactly. But as long as we're clear about it, it still can be valuable for Lenka. I hope this answers your questions at the moment. You already referred to the world. Let me take a sip of water, Michael, because you've been talking like crazy. For those of you who've just joined us, welcome here at EEO's Just Ask. This is your live virtual appointment with an expert in implant dentistry. And today we're talking to Michael Payet about everything related to ceramic implants. And Michael, you just already referred to, if we don't see any information, I might put it to sleep. And I think that's a nice segue to another question that was submitted, a second case submitted by Jens Taerts, which is related to the topic of peri-implantitis. And what do we know about the relation between ceramic implants and peri-implantitis? What's there to say at this moment?
I think that's also a very, very relevant topic if we speak about ceramic implants, because it's always discussed, is there really less biological complications around ceramic implants? And Jens was submitting a case where he placed a zirconia implants in the position of the first molar, and after 2 years of loading, he could observe this saucer-shaped defect, inflammatory defect, as we know it from titanium implants, and giving all the clinical signs of peri-implant infection. And what he did, and what it was interesting, the patient was also developing a peri-implant infection on the other side, on a titanium implant. But what Jens did was obviously the right thing. He removed the screw-retained crown, also carbon fiber two-piece crown here, and but the crown was not carbon fiber, but the connection with the screw. This is the titanium implant on the lower left side, also having the signs of peri-implant infection. And what he did on a zirconia implant was just removing the crown, did the cleaning, removing of the tissue here. And of course, you need to be very careful with the treatment of the surface. So the only thing is you can do is remove the tissue with carbon hand instruments, in order not to harm the surface and make local disinfection. And he was following the case, and after 2 years more, you could see quite a osseous reattachment on the zirconia implant, and without any further measures. It was just reinstruction and strict recall protocol, and this is something which is quite impressive, because I've never seen this on a titanium implant. So that's a nice case, and a healing pathway which you don't see too often in daily clinics. Having received this case, I looked into my own cases, and I could see on one of our cases where we placed some single-piece implants in a patient in the maxilla. Was not, in this case, it was single-piece, as I said, single-piece implants, 3 in a row. And we were following not the immediate loading protocol, but this patient was wearing a protection splint for the healing period of 3 months here. And a friend of mine, Gerrit Fritz, who was doing the prostate work, and in a conventional manner, in the regular impression technique, he was inserting a bridge in order to stabilize the implants against each other. We can discuss whether this is necessary or not. Anyway, so he did it, but he was inserting the bridge. Everything looked stable at this moment. Then he took an X-ray, and then we were not very happy, because we could see some drawback here. We could see also here some signs of peri-implantary infection, also a saucer-shaped defect. And so we cleaned it clinically without any surgery. We did a reinstruction. We did a local disinfection. And the clinical situation developed in a very nice way. But what we saw in the radiograph after 6 months was the phenomenon also Jens was seeing. We could also see the healing of this osseous reattachment around this last zirconia implant. And also this is something I've never seen. I've never seen in titanium implant. So it's not that the X-rays are mixed, but this is the 6 months later, and this is the first at the insertion of the crown. We can still see a little bit we may call it the scary sign here, but it's an osseous attachment, and this is something that I've never seen on titanium implant here. So this might be that there are pathways of healing around zirconia implants which we still need to observe on a longer row, and we are very curious to do so.
Are you saying these are the 2 cases, or one case Jens submitted, one case I could find in my own archive? This is what we have. So you say we see hints, or we find some spectacular cases where we suspect ceramic implants might do better on peri-implantitis, or is there more available already?
That's the question, of course. So there's not too much more, but this is the topic we always need to discuss. There's one publication which gives us some let's hopes is probably not the right term, but gives maybe some indications that there might really, in fact, be less peri-implantitis around zirconia implants. That's a publication by Stefan Röhling, and they induced on purpose with the help of ligatures peri-implant infection around titanium and around zirconia implants in a dog model, and they could see significantly less inflammation around the zirconia implants of this iatrogenically induced inflammation around implants. So that's an animal experiment. So we don't have any solid clinical data on this. So
very, very, very promising, and this is published this year, right?
This was in 2019, so it's really very recent. So there's really something we can maybe build on, and the new studies will come. What is really obvious also, there's when you look for the typical peri-implantitis around zirconia implants. If I was screening my own case, but also if you talk to other colleagues who do a lot of zirconia implants, it's hard to find it. So,
which is another hint. Again, we're talking about hints. We're talking about empirical, not even evidence yet. We're talking about observations, but they all look very promising, and they are pointing in a direction that there could be a relation here. So I guess key takeaway: more research needed into this direction. And obviously,
Definitely.
when more and more ceramic implants will be implemented, well, we'll have to find out whether the observations keep pointing in the same direction, right?
Absolutely, absolutely.
Well, let's take a question. Let's first say hello to Stefan Fickel. We know each other from other live shows here in the EA context. Good to have you with us, Stefan. John Dipsey is submitting a question, but first I want to take Dimitris Sokol's question. He's joining us from Athens. Welcome, Dimitris. And he's asking, what type of hand or ultrasonic instruments can we use to clean zirconia implants? And I think it's very much related to the case you've just shown. What do you use when you clean ceramic implants?
So since we don't do peri-implantitis treatment on a regular basis around zirconia implants, so that's only a recommendation which we do. So we try to do it as minimal invasive as possible. So you should not use the air abrasive devices, which we are using on which we very much like to use for the treatment of peri-implant infection around titanium implants. They are very effective and very quick, and also we do not like to grind. If we speak about the resective therapy, that we take away the threads just to polish the surface, because this may induce these micro aging, micro fractures, and everything. So it's some kind of carbon instruments. I wouldn't use the sharp scalers, really just to remove the scarry tissue, the infected tissue. Don't touch the surface. Touch the surface as little as possible. I could see some little scratching scars on Jens' implant here. I think it was used, but it was black. I think it was the scratches from carbon instruments. So I would rather go for a local disinfection with superoxide or whatever is available, and try to reduce bacteria in a chemical way and remove the tissue as gentle as possible.
Exactly. And I guess it's the third time you mention it, but people might have not joined us from the first 5 or 10 minutes. The key message here today is that the protocol with the zirconia material is that you're not allowed to, well, touch it is not the right word, but not to scratch or polish it, because that might change the properties of the material, right?
Absolutely, yeah.
Good. Let me go to John Dipsey's question, and it's kind of off topic, but let's do it a little bit in between. He's asking, hi everybody, are ceramic implants more sensitive to primary stability, meaning torque, and bone type during insertion than titanium? What is your experience there, Michael?
I think it does not depend. Also, this is a very important question also, especially for the single piece implants, because in these implants, we are really looking for primary stability, because we always have this immediate load application. And if you want to go for immediate provisional restoration, you need at least, this is what the literature tells us. So this is what we were aiming for, something like 30, 35 Newton centimeters. And this depends, I would say, also not so much on the material, but more on the design of the threads and the height of the threads and everything. So we've, as I was saying in the beginning, we've been using several types of zirconia implants, and there were some designs that allowed us really in a very predictable way to achieve primary stability. If we use, I can see this in some of the manufacturers' surfaces and implant designs, that there's an extreme amount of primary stability, which sometimes I do not feel too comfortable, especially not since I had this experience of fracturing one zirconia implant. But I have to say, just not to defend, but just to clarify, I also fractured already a narrow diameter titanium implant during inserting it. So this happens also with the titanium, with the 3.5, 3.3. So that's, if you don't follow the surgical protocol, which I did not at that moment, this can happen in both times. So I don't think it's too much a it's too much a question of the material, but it would be interesting whether the material has an effect. And I think that's a good topic for a master thesis. So I will ask my students tomorrow whether someone can cover this topic. So that's exactly. Maybe a good idea.
Yeah, so no clear evidence yet. Your experience is based on clinical experience, and perhaps someone gets a master thesis project out of this.
Yes.
Live. Just ask. Just one small step back. Sasha Marin is still asking a question related to the topic of peri-implantitis that we were just discussing, and that reads: what about laser treatments for peri-implantitis around ceramic implants? Do you have any either knowledge about studies or at least some experience with that yourself?
Yes, there's one study from the group of Frank Schwarz, and they've been Erwin Yak laser to perform the treatment of zirconia implants, to perform the treatment of peri-implant infection, and which had the similar outcome as for titanium implants. But also here, I would be very cautious using hard lasers on a zirconia surface. What definitely is an option is to use photodynamic therapy with the soft lasers, that you have a photosensitizer, which we also use in periodontology, just to reduce bacteria, which is just by the photosensitizing effect, this can kill microbiota as well. So photodynamic therapy with toluidine blue or with methylene blue is definitely an option, and probably also a good idea to be used as an additional tool to reduce bacteria around zirconia implants.
Exactly, and Frank Schwarz and his group have been doing some studies about that. If you want to read more, Sasha. In the meantime, Stefan, it's not that I don't want to take your question, but since you arrived a little late to the party, let me refer to the recording of this Just Ask that will be available on the EEO YouTube channel right once we stop, because Stefan is asking about your opinions on screw-type connections, but we've already covered that topic quite extensively before. So Stefan, just scroll, I think it was about 15 to 20 minutes into the broadcast, and there you can see Michael's experience and announcement of a new multi-center study into that. So that's interesting news. So,
but let me say hello to Stefan. Glad you're here.
Exactly, and stay tuned and send in more questions, because Laurens Swart from Cape Town, South Africa, is just joining us as well. Welcome, Laurens. We have been covering several topics regarding ceramic implants, starting from the history to the material characteristics to two-piece connections, peri-implantitis, and then there's one big topic we haven't addressed yet, Michael, and that is a question or a case also submitted by Joe Herman from Germany related to the aesthetics of ceramic implants, and he had a specific question regarding papilla formation.
Absolutely. So that's case number 6, and also the last case that was submitted with the question: is it easier to form papilla around zirconia single piece implants? And he was showing us this case here, also of a premolar here. There's a lot of premolar cases, as it seems, that have been submitted. First premolar in the maxilla, I would say straightforward case, nice soft tissue conditions, nice bone, local bone there, and he was inserting this implant and following the prosthetic protocol, and this is the result of the crown work. And also here you can see very nice papilla formation. It was the first provision, and this was the final restoration after some months. And so the question was, we can see very nice papilla formation here in this case, and this is just an exemplary case, which we observe in many times when we use zirconia implants, but we have to say at this stage that the evidence to confirm this is still very little. But if I look at the literature, just to answer this question, there's one very recent, there's 2 recent publications by a German group that say that there's a very nice and promising outcomes of single-piece implants used in the aesthetic zone by Knieha and co-workers. And there's another study addressing exactly this question, also using the same type of single-piece implants that the group could observe independent. This is really interesting, independent of the biotype, of the gingival biotype. They could achieve a very predictable papilla formation in these single tooth gaps with the single piece implants. So that's also why it's one study, but it's also maybe something that where we can get more in the future. I know several working groups are into this topic, so we cannot explain it with evidence, but we can say to Joe that other people observing the similar things he's observing as well. But maybe let me add also some additional information. He was using the single piece implant, which has the shape of a tissue level implant, and we can compare it also. If we compare it to a bone level implant, with the tissue level implant, especially with single piece implant, we have the gingival margin very often at a higher level than at the bone level implant, because if we respect the biological width, it will start here at the higher at a higher reference point than we see it at the bone level implants. So that's maybe also one favorable explanation, just to explain this outcome of his case. So it's maybe the material, but it's also maybe the design of the implant a little bit. This is something which we try to overcome also with individualized abutments for the bone level implants, and also with shaping of the soft tissue with provisional restorations. And that's
so again, little evidence, but cases, several cases seem to hint in the direction that the soft tissue, both in the peri-implantitis discussion as in this case, the soft tissue seems to be happy, if I can say it in layman terms, around these ceramic implants. Is that correct?
That's what we observed. That's what really seems to be the case. Also around zirconia crowns, around zirconia abutments, the soft tissue seems to react in a nice way, but everybody's talking about it, but this is really not yet supported by clear controlled data, randomized clinical controlled data.
Exactly, and that's what we need to have. Before we might figure out how and where this might happen, let me take Alberto Salgado's question, which he reposted. So he really wants us to address it. Thank you, Alberto, for staying with us and reposting the question. He says, interesting, zirconia implants in a difficult environment. For example, a sinus lift with lower BIC. That's a case proving osseointegration. I wish to have more follow-up on that, he says. And he says, are you aware of any studies, either ongoing or already finished, of these more complex cases where ceramic implants are being used?
Not yet. So we've been using a part of the studies. We've been using ceramic implants almost in not in every indication, not for edentulysm, but in cases where we did bone augmentations as well. And so we could not observe differences in the outcomes in these kind of patients. So osseointegration again seems to work, but again there's no data, there's no study that I'm aware of augmentational cases that have been solved with zirconia implants. So that's definitely a topic we still need to work on. Also, zirconia implants in sinus augmentational cases. There was one case submitted by with the PEAK component case that was obviously worked in that environment, was a simultaneous sinus lift. I can remember one case being presented during the SK conference last month in Zurich with bone blocks. Also, obviously, this seems to work. So, but I think we also here for answering these questions. We need to wait for the studies to come along. But the first data, which clinical observations seem very promising, also for the complex cases. But let's do it step by step.
Yeah, so for those viewers who've been with us throughout the last hour, this is starting to become a repeating mantra, right, Michael? We need more evidence, we need more studies, we need more cases. Well, in order to build and fill more studies, we need more cases and more applications of ceramic implants to study them and then draw broader conclusions. I think that's a nice segue into a last topic you've prepared, and that is about why would clinicians in the clinic, or why would patients, or both of them, choose for ceramic implants at this moment? What can you share about that?
Absolutely, I think that's a necessary question we need to answer also to the audience. Why should we use ceramic implants? And to be honest, most of our patients, at least in our clinic, we've been treating within clinical studies. So there was a scientific interest in that. And but what we could see from the studies that the application is getting more and more predictable, and that it seems to work also in standard indications. So, but so far we don't push the topic. So if a patient comes to our center, it's more a patient-driven decision, and this is what we see very obvious. The patients really like to have the idea of a metal-free solution. We also can see this in the supracrestal works. So the patients like to see metal-free crowns and bridges, and also from the filling technique going away from the amalgam fillings to the composite fillings. So that's something that people are very acceptable, or how should I say, they really like to use this. They really like the ceramic implants as an alternative. So if a patient asks
what
us,
am I looking at here, Michael? This study, was this in your clinic? Because I can imagine that if people go to Michael Peri, they would prefer ceramic implants. Or is this a more generic?
It's a more generic study that which has been done by a manufacturer, and if you could see that among 100 patients, the majority does not know, but at least 3 times more, if they have the option to use a metal implant or a ceramic implant, they would go for a ceramic implant. And this is what if you leave the option to the patient.
Exactly.
So that's the patient is for us is the drivers, and we can and the patient who asking for it, we insert it into these patients. Another fact that it is always or needs to be addressed when we talk about ceramic implants. Is there any sensitization possible against titanium? And there's some immunological reaction. There's some literature, there's some data out there, not only from dentistry, but also from the orthopedic world, also from the cardiologists, where they have dermatologists, the cardiologists. It's very interesting when they were inserting pacemakers. In some cases, which are made after titanium, there's in some patients they see local cutaneous reactions of inflammations, and in some patients they need to replace, and we need to cover the pacemaker. So obviously, in some patients, fortunately, in really a very, very small amount of patients, there obviously is. There could be immunological reactions, and there's one type of testing which is called leukocyte stimulation test, leukocyte transformation test. It's a blood test, and patients, I don't know in other countries, but at least in our countries, at least if they have gone through unexplained implant failures, very often have these kind of tests and come to our clinics. And I'm quite amazed always about the diagnosis that comes out of such a blood test. And I can show a case here. And this is also the question we have to put here, whether zirconia is the solution for these patients. And there's one case I just would want to show you at the end. Where a friend of mine has been inserting 6 implants with following sinus implantation, sinus floor elevation, and this patient lost all 6 implants within a couple of weeks with abscess formation, and really it was quite a dramatic reaction towards these implants. So he lost them all, and then the patient went to take this leukocyte stimulation test, and he came with this test to us, and there was a degree, I'm not an expert in that, was degree 3, that says that he's got, I don't know, a 12-fold higher or multiple higher potential reaction towards inflammatory reaction towards titanium. So he came to our clinic, and he was asking us whether we could place maybe some ceramic implants because he needed some retention. And so we were inserting 2-piece implants. This was already also at a very early stage. It was in 2011, and this was after surgery. And so he lost to make it short, he lost 2 of these zirconia implants, but 4 survived. And we are following this case for almost 8 years now, and he's having a telescopic restoration, and we don't see any sign of inflammation in this patient. So it did not work with titanium, at least worked in 4 implants in this case. And so we are following these cases. There's another case of a patient with an unexplained implant loss in the lower right side. Also, she had this kind of test, and she was asking for a ceramic test. And these are the patients where we're placing ceramic implants very often in our clinic. Also here and here you can see it's a 12-fold high risk for titanium implant failure. So when a patient comes with a medical diagnosis like this to your office, you would not insert a titanium implant again. And we could solve this case with a zirconia implant here. So after 10 years of more than 10 years of daily clinical application of ceramic implants, I think we should conclude, Gerrit. What do you think on the topic a little bit for the audience?
Yeah. I have 2, at least at the moment, 2 questions that I want to pitch to you. So before you go into conclusion, one is, I think, very much related to what you were about to say. It's from Herbert Valentin, who first of all congratulates you on the presentation. He says, nice presentation. And what about the long term of ceramic implants? For example, 10 years of follow-up. How much study is there? Well, we've already concluded this is quite a young field. We saw the earliest applications, first generation, 2007, 2008, 9. So basically, we have just arrived at the first patients who are at a 10-year stage. So I think you were about to hint to anything that we know at the moment about long-term. Well, long-term, medium-term, I guess we are at most.
Absolutely. So we're here at the midterm or early stage. So we can conclude that the survival and success rates really seem to present similar for the short amount of time which we observe. So far, we have to confess that there doesn't seem to be a clear scientific advantage, but it may be advantages in patients with immunological reactions, which are fortunately very rare around titanium implants, because this is something we have to stress. Titanium has been a huge success story for the last 40 years of its clinical application. So far, we do not see the scientific benefit in regards to aesthetic and also nor to peri-implant infections, but the first clinical observations, I would not call it even results, but the clinical observations are very promising and fascinating. And aging within the time frame which we observe does not seem to be of clinical relevance. I don't know how we make just ask in 10 years whether we can have on this topic, whether we can have the same conclusion. I really hope so. But at the moment, as I said, there was no fracturing so far. The single-piece implants, they perform very well in surgery and also in prosthetics. There's a little bit of a learning curve in the beginning because the protocol is slightly different, but probably the breakthrough for zirconia, for ceramic implants, will be a predictable and a well-documented screw-type connection between abutment and zirconia implants. And this is something, and here we have to wait for the data, and I really hope that we can contribute in some way that we can give recommendations soon.
Exactly. So in summary, very promising results in clinical practice, yet a lot of work to be done to give it enough scientific backing for this to go all on. Just a nice practical question, I guess, to take us to the last one. Brunilda Gashi is asking, so if she understands it correctly, our zirconia implants would be the best choice to prevent interactions during the MRI, aren't they?
Yes, we can answer. We can answer this.
That's a yes in short.
This question. Yes, that's a clear yes.
Great.
Yeah.
Great. So with that, we had a little over an hour with Michael Payet from the University of Graz in Austria. And if you are enjoying this, make sure you mark your calendar for January 9th, where we have the next Just Ask Live, where we talk all about soft tissue management with David Nisand. If you have any cases you want to have submitted for that Just Ask, go to the eao.org website /justaskcasesubmission and just upload as much information as you can about your case, whether it's x-rays, scan pictures, clinical photo or video, and make sure you get proper approval from your patients to submit this case to this scientific meeting, which is also in public, or make sure the case is very well anonymized, so there's no issues there. Let me start with thanking you, Michael. This was a great experience. Thank you all for sharing this knowledge, all your knowledge. And thanks also to all the case submitters, of which many of them have been sending their thanks in the live chat, Michael. So once we sign off, you should go back and read that all. Joe Herman is here, Jens Starts is here. They're all here. And well, a lot of nice and happy waves are rolling in. So how is this experience for you, Michael?
Thank you, Gerrit. It was a great honor. First of all, I have to thank you and the EO for giving us the opportunity to talk on this of one of my favorite topics, and it's been a lot of fun, and I really enjoyed it very much. And thanks to the audience, thanks to the submitters. We hope that we could deliver some good take-home messages. Thank you.
Exactly. Now, three more last important things to do for our audience. If you haven't done so, hit subscribe right now here on YouTube, so you'll be the first to know when a new EEO video is published or when a new EEO Just Ask will go live. And we have many more scheduled every month coming up in 2020. Secondly, if you know anybody who might be interested in the topic of ceramic implants, make sure you share this video with them, because as soon as we stop the live show right now, this video is available as a recording, and you can share and watch it with your staff, with your colleagues, with anybody who might be interested online or offline. So please do that, so together we can advance the field of implantology. And thirdly, I hope that you will be back with us January 9th with the third EEO Just Ask. And with that, I think we're going to sign off, Michael. Thanks to all for your participation. Thank you, Michael. And I hope to see you next time.
Thank you.
Either in person at one of the EEO meetings or back here on the EEO channel.
Thank you. Bye-bye.